I now request Dr. SARATH Ravi to present his talk on OCT biomarkers in diabetic macular edema.
I'll be talking on diabetic macular edema, how OCT helps in imaging. Diabetic macular edema is one of the most frequent cause of a reading vision loss, and most of the patients with more than 20 years of diabetes, almost 1/3 of these patients have some form of diabetic macular edema. So this was one of the diabetic patients who came to a retina OP for a routine fundus examination showing a non-proliferative diabetic retinopathy. There is no obvious macular edema, but on taking the OCT, you have a center involving edema which required anti-VEGF therapy. So why is OCT important in DME? Because it's more sensitive than a clinical examination in picking up subtle edema, as well as it is non-invasive, non-contact. The resolution is very high, so you have the structural changes visible very clearly. You can pick up interface abnormalities, and based on this, you have the treatment options, assess the response to therapy, and plan your retreatment. So, in the era of OCT imaging, we have been introduced to this concept of a center involving and a non-center involving edema. So, what is a center involving edema? It is a central subfield thickness of 250 microns or edema within 500 microns of the center of the macula, or any edema more than one disc area within one disc diameter of the macula. So in other words, it's a blend of earlier clinical significant macular edema with OCT parameters. So in diabetic macular edema, you could have any of these patterns. And a spongy edema is a diffuse thickening of the retina with hyporeflectivity at the outer plexiform and the inner nuclear layer, and usually you have a good response to treatment. Whereas in cystoid edema, you have the fluid accumulated within well-defined spaces in the outer plexiform layer, and based on the size of the cyst, they could be small, large, or giant cysts, and the larger cysts are associated with macular ischemia. So what determines the visual acuity is not just the presence or absence of the cyst, but it is the number, the size, and the location of the cyst, and also the amount of the residual foveal tissue. So if you look at the cystoid process, sometimes there could be bridging retinal processes which are vertically oriented hyperreflective lines, and these lines actually connect the inner and outer retina, and these are a positive biomarker. So whenever you have these bridging retinal process, it indicates you have a better visual response following therapy. An absence of bridging retinal process, it usually indicates a poor prognosis even following therapy. In a cystoid degeneration, sometimes you could have a prominent foveal cyst, and this is causes reversal of foveal contour, what we describe as a foveal eversion. And this foveal eversion is one of the biomarkers for a poor response to anti-VEGF therapy and also rapid recurrence following the therapy. And some cystoid processes may have hyperreflective material within them, and complete occupancy of these hyperreflective material within the cyst usually is due to a long-standing edema and indicates a poor prognosis, and also patients with ICHRM have a poor baseline visual acuity. The other type of macular edema is a serous retinal detachment. You could see where there is a hyporeflective space behind the neuroretina. It usually correlates with disruptions in the external limiting membrane, and most of the studies showed that patients with subretinal fluid usually have a better response to treatment. And there is an increase in inflammatory mediators in these patients, and they respond better to DEX implants. A subset of patients may have vitreomacular interface abnormalities, which could be either a frank VMT or a taut posterior hyaloid, and these patients do not do well with medical management alone, and they need surgical intervention in the form of vitrectomy and ILM peel. And this is one such patient with diabetic macular edema along with epiretinal membrane, underwent combined phaco with vitrectomy and removal of the ILM and the epiretinal membrane. And these patients do reasonably well when this vitrectomy is combined with your anti-VEGF or with the intravitreal DEX implant. More often you have a combination of patterns like a combination of cystoid edema and neurosensory detachment in this patient. So OCT helps to identify specific biomarkers that are important in identifying the baseline visual acuity as well as the visual response to therapy. And the earliest used biomarker was the central subfield thickness. Like Dr. Manoj told, the central subfield thickness is the retinal thickness that is computed in the central 1 millimeter zone. And how good is it as a predictor of best corrected visual acuity? The protocol A study of the DRCR network showed that at the best there is a modest central subfield thickness alone is not a good or accurate predictor of the best corrected visual acuity. The other biomarker is the disorganization of retinal inner layers. It's a disorganization of the inner retinal layers like the inner plexiform, the ganglion cell layer, the inner nuclear and the outer plexiform layers. How to identify it is you start tracing the inner retinal layers towards the fovea, and where the borders between the layers get indistinct, drill is present. And when the horizontal extent of drill is measured in microns, and when drill occupies more than 50% of the central 1 millimeter zone, it is supposed to be associated with a poor visual acuity, and it is often seen in severe forms of diabetic retinopathy associated with loss of outer retinal layers as well, and usually has a poor visual prognosis. Like in this patient where drill was present, even though the anatomical response to the anti-VEGF therapy could be good, your visual response is suboptimal. The hyperreflective foci, it's seen in most vascular conditions, also seen in diabetic retinopathy. You have these distributed mostly in the inner retinal layers, and their size is less than 30 microns, and the reflectivity is similar to the nerve fiber layer. They are biomarkers of retinal inflammation, and these patients do better with steroid implants. And also, if a patient has more hyperreflective foci at baseline, it indicates a more active form of DME and a poorer response to treatment. So to differentiate it from hard exudates, the hard exudates are larger, more than 30 micron size, located in the outer retinal layers with with the back shadowing, and reflectivity is similar to the RP Brux layer. So hyperreflective foci could be also present in outer retina when there is a disruption of the external limiting membrane or the ISOS junction. They could be present in choroid, and it is indicative of a poor prognosis, and also in severe forms of diabetic retinopathy like a proliferative diabetic retinopathy. In a long-standing edema, you can have a pearl necklace sign, which is the arrangement of hyperreflective dots in a linear pattern on the inner wall of the cystoid process, and usually they leave behind visible hard exudates and rarely disappear completely. And it's seen in when subfoveal in location, they are associated with a poor prognosis. The outer retinal layer continuity is another biomarker that has got prognostic significance. You look at the external limiting membrane, which is actually the plexus between the Muller cells and the photoreceptor cells. And whenever the external limiting membrane is disrupted, fluids start entering into the outer retina. And these disruptions in the external limiting membrane are associated with disruptions in the ellipsoid zone. So ellipsoid zone is nothing but the photoreceptor layer, and percentage disruption of the ellipsoid zone has got prognostic significance. And therefore, patients with the disrupted ellipsoid zone have a poor visual acuity, and on a timeline, the ELM disruptions occur earlier than the ellipsoid zone disruption. The choroidal thickness can be measured either by a manual method or by an automated image processing, the mean choroidal thickness being lesser in patients with DME. And if your DME patient is having a thicker choroid at baseline, it indicates a better response to anti-VEGF because of a more intact choriocapillaries and less of outer retinal ischemia and a better preserved photoreceptors. So the other biomarker is a parallelism. You have the outer retinal layers parallel to each other in a binarized image of the OCT, and in a DME patient with large cystoid spaces and hyperreflective foci, you find that the outer retinal layers are not well identified, and so therefore the binarized image is not able to produce any degree of parallelism of the outer layers, and loss of parallelism is associated with a poor visual acuity. OCTA is important in diabetic retinopathy as it identifies disease in the preclinical stages. Like you have increasing FAC disruptions in the superficial capillary plexus, focal microaneurysms in the deep capillary plexus. And as one progresses from the no DR to the PDR stage, you have an increasing FAC dysmorphia as well as increasing diabetic macular ischemia. And this important study by Lee and group published in Ophthalmology in 2016, you showed that the poor responders to the anti-VEGF therapy usually had a greater loss of the deep capillary plexus, not so much so in the superficial capillary plexus at the baseline. And these patients who have a greater loss of the deep capillary plexus, they have a corresponding outer plexiform layer disruption as well. The other biomarker is the macular vessel density. You have the vessel density measured through metrics like vessel area density or vessel length density, and it's reduced in both superficial as well as the deep capillary plexus. So it's a negative biomarker indicating a poor prognosis if the vessel density is reduced. So OCT is an integral tool to diagnose, classify and to prognosticate DME and identify which agent to start your treatment, assess your response to therapy and identify the poor responders, and also to take decisions on retreatment and switching between agents. And it also helps to identify patients who need a surgical intervention. And OCTA has got a promising role by identifying disease in the preclinical stages and also identifying poor responders. Thank you.
One last question. When do we expect that the AI would sit in the OPD and tell us what to inject and when to call the patient next? In how many years?
We don't want, AI is going to help us, especially I believe in diabetic retinopathy, most important thing is screening. You don't need a doctor to screen actually. So those patients will come to you for treatment. So now AI enabled cameras have already come. So that is a primary, I think, the role. And then AI enabled OCTs will come and it will show that, which needs treatment, which do not. I think it's going to aid us rather than replace us.
I think one more point about AI is we have to be strong to give the ground truth. So unless we are going to give that information, the ground truth is very important whenever you plan a AI thing. And for an Indian eye, I think that may not be existent. So I think it's beyond our time.